Hello, my name is Sharon Kettles. I'm an emergency department charge nurse at University of Colorado, UC Health Medical Center, and I just completed my graduate degree for acute care nurse practitioner at University of Colorado Anschutz. This is a novel STI PrEP linkage program in the emergency department. Included in this group of collaborators are ED physicians, ED nurses, ED pharmacists, infectious disease physicians, and a PrEP care coordinator. We're very proud of the diverse group we brought together. The authors have no conflicts of interest to disclose. Some background. 1.7 million people became newly infected with HIV in 2019. Approximately 25% of people living with HIV in the US and 19% of those with new AIDS diagnoses were women in 2018. The CDC recommends PrEP for heterosexual, cisgender women if those women inject drugs or have male sexual partners who are living with HIV, inject drugs, or have male sexual partners. Also recommended in cisgender women who live in a high HIV prevalence area, who are sex workers, or who have had a sexually transmitted infection diagnosis in the last 6 months. Most research on the use of pre-exposure prophylaxis, or PrEP, for HIV prevention has been among men who have sex with men and transgender women. While MSM PrEP enrollment has skyrocketed, PrEP prescribing and use among cisgender females has flatlined. The emergency department is a common location for new diagnosis of STIs and is often used as a form of primary care. Having an STD can increase your risk for getting HIV, not only because they are transmitted the same way. STDs can cause a break in the skin, making HIV transmission easier. PrEP, when taken with good adherence, with Truvada or Descovy, can significantly reduce the transmission of HIV via sex, especially in the MSM population and IV drug users. While ED physicians are aware of PrEP, a recent survey showed that few were familiar with the guidelines at 23.9%, and less than half, at 43.3%, were comfortable discussing PrEP with their patients, let alone prescribing or referring. We developed an ED-driven interdisciplinary program to refer high-risk patients directly from the emergency department to the PrEP clinic. As physicians are often uncomfortable with prescribing, an alternative pathway could be helpful to remove the ED physician from the process. With our program, the process was pharmacy-driven and prescribing was delayed until the patient could be seen by a PrEP provider. Our pathway, facilitates all these steps via a campus-dedicated clinic. Here you can see the recommended PrEP care continuum proposed by none et al. Based on 4 years of experience with PrEP implementation. The first 3 steps in the continuum focus on PrEP awareness, identifying individuals at highest risk, enhancing self-perceived HIV risk awareness, and raising overall PrEP awareness. The next steps, 4 through 7, focus on PrEP uptake, with facilitating access, linking to care, prescribing, and initiating PrEP. And the last 2 steps focus on adherence and retention. On to our quality improvement project. At baseline in our emergency department, if a patient is positive for chlamydia, gonorrhea, trichomonas, or BV, they are routinely notified by an ED pharmacist, advised to abstain from sex, and offered partner treatment where applicable. Our intervention period from March to December of 2019, during those phone calls, the patient was offered a phone call from the PrEP coordinator to discuss HIV prevention and advise on other STIs that were not tested for. The coordinator in the PrEP clinic tracked when the patient was contacted and what follow-up was scheduled for QI purposes. The demographics of our study, our review. STI positive in the emergency department was 289, with 74% of those being female and 46% of those being under the age of 25. 54% of patients who tested positive consented for a follow-up call. The script from the pharmacist went as followed. STDs could put you at risk of getting HIV. Would you like a call for information on HIV prevention from our PrEP clinic? After speaking with the coordinator, 89.2% declined PrEP. 17 people scheduled, 7 showed up to their appointments, 5 started on PrEP with Truvada, and unfortunately, none continued follow-up by 6 months. This is just a review of our retention. Our results are similar to an observational study conducted at a Detroit STD clinic to evaluate uptake, initiation, and persistence of PrEP. With their study, as you can see, of the 161 eligible patients, 71 were prescribed PrEP, which is only 44%, 76% filled the prescription, and the mean duration of use was under 6 months. So in conclusion, many young women with recent STI diagnosis in the ED were possible PrEP candidates, but few enrolled. This was also evidenced in an observational cohort study from Ridgway et al. That showed that women are less likely to perceive themselves to be at risk, despite meeting objective criteria for being at risk. Interestingly, in the Ridgway et al. Review, once they were educated that they met objective criteria for being at risk, they were interested in PrEP referral. Unfortunately, the CDC indications exclude women who do not know about their partner's risk factors. There was a systematic review published in 2018 that suggested potential barriers, and limited knowledge was just the beginning. Factors that influence decisions include cost, peer perspective, having women-controlled prevention strategy, physician input, ease of accessing services, and medication near their homes. The barriers to care are varied and require a multidisciplinary approach. There was a systematic review specifically with women. A small cohort study showed an emphasis on the stigma of PrEP, especially perceptions from male partners and family members, and difficult communications with providers. Future directions for study. There's a need for dedicated outreach and advertising for women with STDs, HIV, and PrEP. There's a need for further research studies on PrEP in women. There's a need for infrastructure, funding, and further evaluation of barriers. Here are references. Thank you for your time. Please feel free to reach out with any questions to myself or Dr. Frasca. Thank you.
Good afternoon. Today I'm going to be talking to you about the initiation of doxycycline pre-exposure prophylaxis in patients attending an HIV PrEP clinic in Philadelphia. In Philadelphia, as in other large American cities, syphilis and other bacterial STIs are epidemic among men who have sex with men, and rates have been trending up for several years. In 2019, 278 or 67% of Hartiana syphilis cases were known to be among MSM. Of these, 126 or 45% were among men who are living with HIV. The Philadelphia Department of Public Health has been eager to decrease syphilis burden among this population. Health Center Number 1, the larger of Philadelphia's 2 public STD clinics, has run a PrEP clinic since September 2015. So Health Center Number 1 HIV PrEP clinic offers PrEP to everybody 18 years old or older who wants it. The participants are overwhelmingly male, but we do have some trans and cis women. At an intake visit, the risks and benefits of PrEP are explained, baseline laboratory testing is done, and STI testing is performed, including syphilis and GCCT at all appropriate body sites. A return visit in 1 month is scheduled, and then visits are scheduled every 3 months. And folks are retested for STI at each 3-month visit. So many of you may be familiar with the results of the PrEPped trial, which is a randomized controlled trial published in 2015. And this trial demonstrated the efficacy of using Truvada to prevent HIV-1 infection in men who have sex with men. In 2017, the PrEPped group published an open-label extension of the trial offering doxycycline post-exposure as prevention for the development of STI. During this extension trial, doxycycline PEP was taken as a 200 milligram dose within 24 hours after condomless sex. Patients were given enough doxycycline to cover weekly use of 3 doses until their next follow-up visit. Subsequent visits were scheduled every 2 months, and STI testing and prevention services were done at each of those visits. So, the primary endpoint of this trial was the first bacterial STI after enrollment. The N there was 232 with 116 to the doxy-PEP arm and 116 to the non-PEP arm. The occurrence of the first STI in patients on doxy-PEP was lower with a hazard ratio of 0.53. And the incidence of the first STI was 37.7 versus 69.7 per 100,000 in PEP versus non-PEP, respectively. The hazard ratio for chlamydia was decreased, 0.3. Hazard ratio for syphilis was decreased to 0.27, and there was no significant effect on GC, which was not unexpected because doxycycline is not bioactive against gonorrhea. So, in the past few years, the Philadelphia Department of Public Health has been exploring the potential to prevent syphilis in men who have sex with men by using doxycycline PrEP. However, at the time, there were few data available about daily use of doxycycline to prevent syphilis and other bacterial STI, and there were concerns about the development of resistance and adverse effects on patient microbiome. So the dispensation of doxycycline as PEP was attractive because it offered far more limited antibiotic exposure and seemed to be effective. So using the structure described in the French Iberguet extension trial in September 2019, we undertook a program to dispense doxycycline PEP in our HIV PrEP clinic. And this would enable us to dispense doxy-PEP in our most controlled setting where patients were closely followed. At the intake PrEP visit, patients were asked if they would like to initiate doxy-PEP. The dosage, risks, and benefits were explained. If the patient was interested, 24 100 milligram tablets of doxy, or 12 doses, were dispensed. More was dispensed at follow-up if needed. Patients were given the phone number of the clinic doctor to immediately report any adverse effects or if they had any medical questions regarding PEP. And in subsequent visits, PEP was again offered if already initiated, pill counts were performed, or patients self-reported their doxy-PEP use. So now let's take a look at the initiation and dispensation of doxy-PEP. We're breaking our data up into 3-month intervals because it's the period between PrEP visits, and it can also show what happened over time. So here in the first row, you see the total number of HIV PrEP visits that occurred in the given time period. Next row shows the number of new doxycycline PEP orders that occurred during this time. Next row is the total number of doxy-PEP orders that occurred during the period. The next row describes any follow-up PrEP visit that occurred during the time period in a patient who had accepted doxy-PEP previously. And the last row describes the number of patients who had no follow-up visit during this time. So as you can see here, doxy-PEP was highly acceptable to this population. 78.9% of patients initiating the medication accepted it at the start of the program. So let's look at doses taken. 157 patients had a follow-up visit during this time period. Of these, 79 or 50.3% reported no usage, 47 reported taking 1 to 3 doses, 6 took 4 to 6 doses, and 9 took 7 or more doses. No information was available in the medical record for 16 patients, and importantly, no adverse effects were reported to our physician. Looking at the second 3-month period of the program from December 18th to March 18th, there were 253 PrEP visits in total. 78 new patients initiated PrEP during this time, and 26 patients who had previously had PEP dispensed got a refill, for a total of 104 bottles of doxy-PEP dispensed. 56 patients had their first follow-up visit following doxy-PEP dispensal during this time, and 22 had no follow-up visit. During December to March, of the 78 patients who were newly given PEP, 56 had a follow-up visit. These 34 took no doses, 11 took from 1 to 3 doses, 1 took 4 to 6 doses, and no one reported taking 7 or more doses. No information was available for 10 patients, and again, no adverse effects were reported to our physician. So here's the next 3-month period. And as you can see at first glance in this slide, the period from March to the end of June 2020 is not like the others. COVID hit, and the city of Philadelphia issued a stay-at-home order on Monday, March 23rd. The clinic had already closed to in-person visits at the end of the week of March 16th and opened to telehealth visits on March 24th. All PrEP visits were considered non-emergent visits and were performed over the phone. So what happened to PrEP and PEP? Well, scheduled PrEP telehealth visits were relatively well maintained, although there were definitely fewer visits than prior to closure. You could see there were 208 as opposed to 237 and 253. However, there were only 12 new initiations of doxy-PEP and 25 renewals of doxy-PEP, which is very much decreased from the prior 2 periods. Additionally, of those who did initiate a new doxy prescription, none had a first follow-up televisit within this time. However, throughout the duration of the program, doxy-PEP was offered to 352 people, of whom 277 accepted for an overall acceptance of 78.7, even including the pandemic era. As in the eBrigade trial, we had hoped to compare rates of bacterial STI among those who accepted a doxy bottle and either reported use of doxy or did not report using doxy. However, during period 3, no in-person follow-up PrEP visits were performed unless patients were also symptomatic or had a known syphilis exposure. Therefore, no routine STI screening occurred among PrEP patients during this time, so we did do an analysis of rates, but we only included results from period 1 and period 2, even though some infections did occur among known PrEP and PEP patients during period 3. So, calculating the crude STI rates. We looked at the rates of syphilis, CT, and GC, and calculated them by looking at the total number of positive test results by type of infection. And these positive test results were from all reported cases among this cohort in Philadelphia, not just in our clinic. These were divided by the sum of the number of months between PrEP visits for all persons with at least one follow-up visit. Rates are displayed in mean person months that are calculated for those who took at least one dose of PrEP versus those dispensed PrEP, but who didn't take any. So overall, 172 patients received at least one bottle of PrEP and had at least one follow-up visit with STI testing. Doxy use was not reported for 10 of those persons. So you can see here that rates in person months of CT and syphilis were similar among both those who reported taking and did not report taking doxycycline. Interestingly, the rates of GC were much higher in both groups, and there were no significant differences in reported rates for any of the 3 infections. So, limitations of this analysis include that during the period studied, there was a major disruption to clinic operations due to COVID, which resulted in lower enrollment and follow-up than anticipated. When we first started, the medical record had no prompts for collecting number of doses of PEP taken, resulting in some missing information. Self-report of doxy doses substituted for pill counts in many visits, which may have resulted in underreporting of doxy taken in either group. However, we were able to ascertain that the provision of doxy-PEP in our PrEP clinic was feasible, safe, and highly acceptable to our population, with nearly 80% of individuals accepting a doxy bottle or bottles. Most patients did not use many doses, with a majority taking only 0 to 3 doses every 3 months. No adverse effects were reported to us. Though the disruption to clinic operations and lower enrollment rendered us unable to determine differences in disease rates at this time, we plan to continue monitoring the clinic, and we plan for future analysis going forward. So I'd like to acknowledge these following people, particularly Steffi Joseph, and thank you very much and stay safe.
My name is Kate Tresner and I work for the DC Department of Health. Today I'll be talking about assessing sexual risk compensation among PrEP clinic clients in DC 2016 to 2019. A little bit about the background of HIV in DC. In 2018, we had 12,322 people living with HIV, which makes up 1.8% of our population. 51% of those living with HIV are 50 and older. As far as newly diagnosed cases between 2014 and 2018, 1 in 5 were Black women, 1 in 3 were MSM of color, 1 in 3 were 20 to 29, and 1 in 7 had at least one STI diagnosis within the last year. So our new diagnoses are people of color, men who have sex with men, young, and getting STIs. So PrEP and STI clinics are a good place for HIV prevention. This is from an MMWR in 2018 that discussed PrEP indications in the country and by state. So in the US in 2015, 1.1 million people had indications for PrEP. 500,000 of those were Black and 282,000 were Latino. There were actually about 78,360 PrEP users in 2016 and 7.1% of this estimated need. So of PrEP users with an identified race or ethnicity, 11% were Black and 13% were Latino. So Black and Latinos were making up 24% of PrEP users and over 70% of the need. So there's a large gap there. In DC, 13,280 people had indications for PrEP in 2015, and again, most were Black and Latino. The DC Sexual Health and Wellness Center is the only public STI clinic in DC. We began a PrEP program in August 2016. We see about 2,000 patients a year who are mostly male, young, and Black. The patients come in for an intake and they get a red cat survey with our PrEP navigators that are really good at building a rapport for our patients, with our patients, answering questions and making sure that they're meeting all of their social support needs and anything else they might need. And once they meet with the navigator, then they meet with the provider. They do their HIV and STI labs, and then they discuss with the provider. And if they both feel like they're in a good spot to start PrEP, they're a good candidate. They get a starter pack of 7 pills and come back in a week. And then if they both agree to continue and discuss side effects, then they will get their prescription for 3 months, and they come back every 3 months after that. And we do some occasional follow-up surveys and outreach to make sure that we're getting people back in the clinic. So the purpose of this project was to assess whether or not sexual behaviors and STIs changed with PrEP uptake among MSM at the clinic. So we combined clinic records and surveys from REDCap, as I discussed. The intake survey has demographic information, risk behavior, medical history, et cetera. We created a cohort of MSM prescribed PrEP from August 2016 to 2019, and then demographics were assessed by time on PrEP. So a total of 589 MSM were prescribed PrEP, and by the time you get to 12 months, it's dropped down to 29% of that initial population. So as we go forward, we'll talk a little bit about these different groups, the different colors at 3 months, 6 months, 9 months, and 12 months. They are not mutually exclusive, so those in a 12-month group are also in the 3, 6, and 9 months. So they've been on PrEP at least that amount of time as confirmed by chart review. So we explored the proportions of cohort participants on their condom usage, number of sex partners, and positive STI labs, and we compared these using chi-square. So this is the patient demographics. This is race and ethnicity. It's mostly Black and Latino, and they were mostly 20 to 40 years old. And insurance was split between private, public, and none. If you look at any of the different groups, they're on for 3 months, 6 months, 9 months, 12 months, or the total cohort. Their race, ethnicity, their age, all those things are very similar over time. So it didn't really change depending on how long you were on PrEP. We have looked at gender in the past and insurance type. In an abstract I did for CROI, we saw that those who were on PrEP for at least a month were less likely to be trans women or cisgender women, and were more likely to have no insurance actually, which we think may have to do with assistance programs or issues with insurance companies' co-pays. So we're just trying to cut up this data set as best we can, do some different analyses, and to make sure we can improve our program, get PrEP to those who really need it, and reduce any barriers that our patients are facing. So condom use for anal intercourse, for MSM on PrEP and reporting condom usage for insertive anal intercourse, never using condoms increased from 11% out of the 288 that responded to that question at baseline to 17% at 12 months. And similarly for receptive, never using condoms increased from 11% at baseline to 16% at 12 months. Apologies for a little bit of a double negative here, but the main takeaway is that condom use is decreasing. None of the results that I'm showing you are statistically significant. I think that has to do with, attrition, missing data, smaller N. So we're going to keep looking at this information, but we'll talk more about the trends that we're seeing. So graphically, you can see you're looking at baseline on the left, 12 months at the right, and always, frequently, occasionally, or never in the different colors of condom usage. And this is for insertive anal intercourse. And basically, you can see that always using condoms is decreasing, never using condoms is increasing. So there's a decrease overall in condom usage. Same with receptive. The mean number of male sex partners in the last 90 days did not change for those on PrEP at 3, 6, 9, or 12 months compared to baseline. You're looking at mean number of male sex partners on the y-axis and the different time points on the x-axis. And the different colors are the different groups being on PrEP at 3 months, 6 months, 9 months, or 12 months. And so you can see that either across time or across groups, the mean number of sex partners doesn't change. It's somewhere between 4 and 6. For MSM on PrEP at 12 months and screen for STIs, this is the proportion testing positive for STIs. So decrease in chlamydia and gonorrhea from 9 to 6%, and increase for syphilis from 8 to 16%. Again, not statistically significant. And overall, the findings that we're seeing, the trends at least, are consistent with the literature with PrEP use. We're seeing a decrease in condom use. We're seeing an increase in risk behavior from studies in the US and Australia. That's kind of what's been seen so far in the last 2 years. We want to do this over a longer period of time with a larger cohort. We want to collect more test results. Since people in DC go to Maryland and Virginia for care, it's difficult to collect kind of all their STI diagnosis and do the matches between systems. So we want to do that better to make sure we have their full STI history. And, it's difficult to say since they're getting tested every 3 months, are we really seeing an increase in STIs? Are we seeing a testing bias and just picking up more positives? And especially as COVID-19 goes, and there's some at-home testing, but overall we're seeing STI rates go down because people aren't getting tested. What's this going to look like in a year from now? But we do really need to have consistent and efficient data collection. We had a fair amount of attrition. For PrEP, people going off is not necessarily a bad thing, so it's hard to look at PrEP adherence in a traditional way because they may go on and off as relationships change, as their circumstances change. So we're still trying to understand, what PrEP adherence looks like and how we can really understand how to improve it or how to make sure we support our patients the best way we can. And then finally, I did want to do more analyses, more statistical tests, more sophisticated analysis, extend the cohort. But I and many of my colleagues were detailed to COVID-19, and so we were unable to do that in the time we were given. So overall trends, again, condom use decreasing, number of partners stayed the same, chlamydia and gonorrhea decreasing slightly, and syphilis increasing. So looking to the future, we really want to understand, how does PrEP alter risk perception and behavior? Does it matter if they're on for short term versus long term? Do changes vary by demographics? And this current environment and at-home testing, in quarantine, how do we offer safe and consistent PrEP care? What does PrEP virtual care look like, especially with labs? So we're interested to see what we can do to help our patients in the next year. Thank you.
Hello, my name is Phil Chan. I am thrilled to be here today to talk about a biobehavioral intervention for PrEP uptake among high-risk men who have sex with men. I do want to acknowledge and thank the other investigators on the grant, Dr. Moitra, Dr. Nunn, Dr. Vandenberg, as well as a team of research assistants and project directors with help, Kevin, Genevieve, and Sienna. Thank you to the entire team. The study being presented today was funded by the NIH. Thank you, NIH. There are no commercial or competing conflicts of interest. So as all of us know, tenofovir disoproxil fumarate and emtricitabine has been approved in the United States as PrEP, pre-exposure prophylaxis for HIV prevention since 2012. Recently, TAF FTC was approved in 2009. According to the CDC, an estimated 1.1 million adults have indications for PrEP. As many of us know, HIV continues to disproportionately impact gay, bisexual, and other men who have sex with men. And although men who have sex with men constitute only 4% of the population in the United States, they account for approximately 70% of all new HIV infections. It's clear that we have to do more, and this is a key population as we think about ending the HIV epidemic. The good news is that recent studies have suggested that PrEP use is increasing among MSM. It was reported, cited to be 1.7% in 2013, risen to just below 20% in 2017. However, PrEP uptake is still not ideal and still low, and especially in certain sections of the country. STD clinics are well positioned to consider PrEP implementation approaches, especially since in many settings they do engage at-risk MSM and provide safety net care in many settings. This was a study we did a number of years ago, about 4 years ago in 2016, that really reported out the PrEP care cascade in STI clinics. And what we found after referring 100%, about 234 high-risk MSM to PrEP, is that only 11% actually initiated PrEP. And so despite having indications, overall PrEP uptake in STI clinic settings was low. And I think one thing that we noted, and one of the themes of the presentation, is going to be that there was low risk perception for HIVs. We found that almost 40% of people who did not initiate PrEP, it was because they did not perceive themselves as being at risk, despite actually having a number of risk factors. Other reasons included needing more time to consider, concerns about side effects, and financial barriers. I think the low risk perception makes sense. It's something actually that has been now reported in study after study. And as we look back on it and think about it, it does make sense given that many of us, especially when we're younger, often underestimated the risk of certain activities, including sexual risk behaviors. So this was something that makes a lot of sense. As a result of these findings, we proposed and were lucky to be funded by the NIH this study, which was to develop a brief biobehavioral intervention for PrEP uptake among higher risk MSM attending an STI clinic. And so the intervention is called PrEP to Start. I really want to emphasize that we wanted to make it brief, so 10 to 15 minutes. As a clinician myself, I'm always sensitive to the fact that in busy STI clinics that there is no time. We're understaffed, we're under-resourced, et cetera. So the goal of this was to make it as brief as possible, 10 to 15 minutes, and we'll talk a little bit more about that in a minute. In terms of developing the intervention, we conducted some semi-structured individual interviews with higher risk MSM over 30, presenting to our STI clinic in Providence, Rhode Island, who were HIV negative and indicated for PrEP. We determined a higher risk behaviors based on the HIV Incident Risk Index for MSM. This was a risk scale that was developed by the CDC, published in 2012. And when you look at it, it includes 7 factors, 7 questions based on age, total number of partners that you've had sex with, how many times someone has had receptive anal sex, i.e. bottoming with another man, how many of the male partners were HIV positive, how many times you had insertive anal sex with a man who was HIV positive, and how often in the last 6 months either you used methamphetamines, such as crystal or speed, or used poppers. And these were based on some large cohort studies that evaluated HIV incidence, and these were the 7 variables that fell out as really being significantly associated with HIV infection, which is why they're part of the scale. They found that a score of 10 or greater was used to determine if the individual was higher risk and a candidate for PrEP, and this is what we used. We based the intervention on some behavioral theory, and specifically the self-regulation theory, which specifically addressed low perceived risk to address that, and we'll talk more about that, as well as promote values related to HIV and STI prevention. The intervention also delivered normative feedback, which we felt was important to put a person's risk behaviors in perspective and how they compared to others. And we found that a lot of people who reported multiple partners with condomless sex actually felt that they were at low risk for HIV. And so part of the intervention was designed to help educate people and provide some of this normative feedback to put their risk behaviors in perspective. We also included decisional balance, which talked about the pros and cons of taking PrEP with the thought of looking at values and really weighing the pros and the benefits of PrEP use. The goal of the intervention was to motivate people to consider PrEP, and again, specifically by discussing their risk of HIV infection and identifying personal barriers and considering problem-solving steps. We used a motivational interviewing approach, which was a non-judgmental discussion of the benefits and implications of taking PrEP and how this decision might align with one's values and goals. We specifically came up with a checklist that people filled out before they underwent the intervention. And the goal of this checklist was used to identify barriers that we were aware of that had come up in PrEP care, as well as that we found in the qualitative interviews. And this allowed the intervention to be really time efficient and focus on the most salient topics versus covering everything. And I think one thing that we wanted to be sensitive of is there really wasn't time in the day to cover everything. So if you look at this checklist, it goes over pretty much all the major reasons why someone may not want to take PrEP. For example, I don't know enough about PrEP, not concerned, so getting at that low risk perception. I don't like taking medications every day. People might think it gay, so touching on stigma, touching on distrust in the medical system, also including things like access to care, difficult to find a doctor, not having transportation, also on cost issues as well, not having health insurance, not being able to afford out-of-pocket deductibles or co-pays, and then also talking about and looking at side effects and interaction with drugs, alcohol, or other medications, and always having an option, of course, for other. We also did some education as part of the intervention, and one thing that we found is that there was a little bit of misinformation out there about different HIV prevention approaches that we tried to correct. And specifically, we used this graph, this visual. And what it shows here is that it really put where PrEP falls in terms of efficacy on the HIV prevention approach. And you can see here that, of course, and one thing that we wanted to emphasize, and especially with serodiscordant couples, is that for people that had an HIV positive partner, it was really key to get them on treatment. And that in of itself was one of the most effective HIV prevention approaches. We also wanted to promote condoms, but we also wanted to be realistic with people, and I think all the real-world data supports this, is that condoms in the real-world setting are not 99% effective. They're 99% effective when used correctly and accurately and every single time. And what we found, and certainly many of you I'm sure agree with, is that they're not used correctly. They break, they slip, et cetera. And so the studies that have been published on this do show that they're about 70% effective, even when people try to use them all the time. We certainly promoted condoms and encouraged condom use, but we wanted to be sensitive, especially to people that did not want to be on PrEP because they were, quote, using condoms all the time, despite having multiple partners, and sometimes more than 5 or 10 partners a month. So we wanted to really push PrEP and really put it in perspective, while also being sensitive that PrEP was a personal decision that each person had to make. After the formative work, we did conduct an open pilot with 19 men. And this was conducted to really finalize the intervention conduct. And we did develop a structured protocol and manual. And I'm happy to share these with people if they're interested in seeing them, if they're interested in considering something like this for their clinic. During this open pilot, all people enrolled did find that the intervention and its components to be highly acceptable. The intervention session did consist of actually 2 sessions. So there's initially a STI clinic for 10 or 15 minutes, again, designed to be brief, designed to be carried out by STI clinic staff, people in the STI clinic. And there was a short, brief second follow-up session, and that was done by phone, actually. And it was actually integrated and with the intention of doing it during result delivery a few days later. And the goal of that was to be 5 to 10 minutes, and again, over the phone, to be as efficient as possible. Finally, and what I wanted to present today, was that we conducted a randomized controlled trial to evaluate the intervention compared to treatment as usual. Treatment as usual meant no intervention, no counseling session, and just a general referral to PrEP services, which is typical for most places. The primary outcome included acceptability, feasibility, and preliminary efficacy of the intervention. This was an R34 funded by the NIH, so it was to look at preliminary efficacy, and it wasn't a full-powered RCT, but we did power it to look at efficacy to some extent, and we'll talk about those results in a minute here. PrEP uptake was defined as attending a PrEP appointment and being prescribed PrEP. So it was really looking at PrEP initiation, PrEP uptake, and not looking at PrEP adherence or retention and care. We did conduct assessments at baseline, 1, 3, and 6 months. Looking at the people that were enrolled, we have completed study enrollment. We did enroll a total of 87 people and 44 for the intervention and 43 for the treatment as usual. One person was withdrawn from the treatment as usual because they were found to be on PrEP after they were enrolled. You can see here the breakdown between the 2 groups, the people that received the intervention and the treatment as usual. There are no significant differences between the 2 groups in terms of age, demographics, gender, or male sex at birth. The final sample consisted of 86 people who have been enrolled, again, 44 in the intervention group and 42 in the treatment as usual. 100% of people underwent the first intervention session because we enrolled them and then immediately did that. 85% of people underwent the second intervention session. So we have a pretty high uptake to the second intervention session as well. The main study finding of preliminary efficacy was that individuals randomized to the intervention were significantly more likely to take PrEP compared to treatment as usual. So 52% of people were significantly more likely to take PrEP who received the intervention versus 27.9%, 28% in the treatment as usual. This was an odds ratio of 2.8, and it was statistically significant. I'll also remind people for our prior work in 2016 is that we found 11% uptake out of all comers who had come to the STI clinic for a specific defined cohort. So this was treatment as usual did result in improved outcomes from that. And the intervention, as described here, did promote significantly higher PrEP uptake compared to treatment as usual, and also compared to historical controls. We performed qualitative exit interviews at the 1-month follow-up and asked individuals about positive and negative aspects of the intervention. We used the 8-item client satisfaction questionnaire revised, the CQSR, which has a maximum score of 32. The results of this among the people enrolled in the intervention were highly positive with a mean score of 30. And again, that's 30 out of 32. We also used a couple study-designed exit interview measures in which item ratings range from 0 to 6, with the 6 being the highest score indicating agreement. People found in general that the sessions were really helpful with a mean score of 5.6, that the sessions helped people better understand PrEP with a mean score of 5.6, and that the individuals appreciated having the initial session at the STI clinic, a mean 5.5. And I think for those of you who have done similar studies or programs, I think we've all found that not having an intervention right on site in clinic, you definitely lose some follow-up, and people can report less satisfaction for that. So in general, very high satisfaction with the intervention and the way it was delivered. In conclusion, the results of this study do show that a brief, and I want to highlight brief again, biobehavioral intervention was found to be effective in promoting PrEP uptake at an STI clinic. The intervention was highly acceptable and feasible in a busy STI clinic setting. Engaging higher risk MSM for PrEP is a key component of addressing HIV in the United States and something that we all need to be better at. And I really do want to promote and state the fact that STI clinics are really an ideal site to consider implementing interventions to improve PrEP uptake because they do, in many places to these towns across the United States, they do engage this population. They tend to engage this population effectively, and they also provide safety net service. So they're an ideal site to really promote PrEP uptake. And again, STI clinics do qualify for funding under 340B, and PrEP uptake can be part of that. It can also be used to leverage that to help sustain the system in general. So with that, I want to end. I do want to thank everyone for their attention, and please do reach out to me with any questions or if I can answer any further questions. Thank you very much.
Today I will be discussing geographic disparities in consistent bacterial STI screening among U.S. men who have sex with men in PrEP care from 2017 to 2018. I'd like to acknowledge my co-authors from both Emory University and Harvard Medical School. My co-authors, Drs. Kelly and Marcus, report grants from Gilead Sciences that are not related to the analysis that will be presented today. Comprehensive PrEP care may be an effective intervention for STI prevention and control. As of 2017, the CDC recommends all-site STI screening for men who have sex with men using PrEP every 3 to 6 months. Co-author Sam Jeunesse previously found in a modeling study that STI screening through PrEP care could prevent 42% of gonorrhea cases and 40% of chlamydia cases over 10 years among MSM. However, this assumes 100% adherence to the CDC guidelines of biannual STI screening. Less than 50% adherence to these guidelines would actually lead to increased incidence of STIs. Are CDC guidelines being met nationally then is an important question to understand whether comprehensive PrEP care can be effective for STI control. Previous studies have looked at this question in specific locales, such as New York City or Baltimore, and have reported wide ranges of consistency of comprehensive PrEP care and STI screening at PrEP care visits. So we are particularly interested in whether there are regional variations in consistency of STI screening at PrEP care visits. And we are particularly interested in the South, where both HIV and STI burden is high among MSM. Our main objective was to quantify the association between residents in Southeast states and consistent screening for STIs among MSM who are currently using or had previously used PrEP. We used data from ARTNet, a cross-sectional web-based survey of MSM in the US conducted between 2017 and 2019. Our main exposure was current residents in the Southeast as defined by the US Bureau of Economic Analysis, and our main outcome was consistent STI screening, which we defined as always, sometimes versus rarely, never, receiving an STI test at PrEP-related visits through a blood sample, urine sample or urethral swab, pharyngeal swab, or rectal swab. And we used multivariable Poisson regression with robust error variance to estimate the association between residing in the Southeast and consistent STI screening. Our sample consisted of 3,259 MSM About 3/4 of them were white, and the average age was 37 years. About 3/4 also reported that they had any private health insurance, and about 17% resided in the Southeast. Of the MSM who reported current or prior PrEP use, 78% reported that they attended PrEP care visits every 3 months, and 10% reported that they attended PrEP care visits every 6 months. 87% of these men reported a consistent possible syphilis screening at PrEP care visits. 78% reported consistent urogenital STI screening, 64% reported consistent pharyngeal STI screening, and 57% reported consistent rectal STI screening at PrEP care visits. When looking at consistency of STI screening at PrEP care visits among MSM by residents in the Southeast, there seems to be no big difference between those living in the Southeast and those not living in the Southeast for consistency of possible syphilis screening and pharyngeal STI screening. However, MSM living in the Southeast seem to report lower consistency of STI screening at PrEP care visits for urogenital STIs and rectal STIs. In multivariable analysis, where we adjusted for age, race, ethnicity, and exposure at anatomical site, for example, insertive or receptive oral intercourse for specific site-specific STI screening, we found that MSM living in the Southeast report a lower prevalence of consistent STI screening for urogenital, rectal, and pharyngeal STI screening, but not possible syphilis screening, and this was statistically significant for urogenital and rectal STI screening. Note that we didn't adjust for systems, provider, or patient level barriers, such as health insurance. We found that consistency of STI screening, particularly for rectal and pharyngeal exposure sites during PrEP care for MSM, is lower than recommended by the CDC, especially in the Southeast. These findings raise concerns about whether comprehensive PrEP care as currently practiced would be effective for STI control. And as PrEP is scaled up in the Southeast, especially through ending the HIV epidemic, resources at the patient, provider, and systems level to support STI screening and treatment as part of PrEP care should simultaneously be strengthened. Examples of this could be expansion of Medicaid, provider education. There are several limitations to this analysis. That includes the representativeness of the web-based sample from an English-only survey, which yielded a sample that was mostly white and higher income. So it may not necessarily be representative of MSM, especially in the Southeast. This was based on self-reported data, which may contribute to overestimation of possible syphilis screening. Exposure at site measurement exposure at the anatomical site measurement is limited to data on only up to 5 partners in the past year. And our outcomes only approximate what we believe would be following recommended guidelines, which is why we considered it consistent STI screening. We assume that PrEP users access PrEP in their current residential zip code. STI screening outside of PrEP care, for example, through another healthcare provider or community-based organization, is not captured here. I'd like to acknowledge participants of the ARTNet survey, funding from NIH, and members of the Epimodel Lab at Rollins School of Public Health at Emory University in Atlanta for their feedback on earlier presentations of this data. Thank you so much. Since the submission of this abstract, our full paper has been published in Clinical Infectious Diseases, which you can access at this URL or this QR code. If you have further questions, I'm happy to answer them in the live Q&A and you may feel free to email me as well.